Dr. Valier's article concerning a new look at the Hawkins classification for Talar neck fractures.
Hello, everyone. I'm Nick Romeo. Tonight, we are discussing Dr. Heather Valier's 2014 paper on reevaluating the Hawkins classification for Talar neck fractures, specifically looking at what factors are predictive of osteonecrosis. Dr. Valier, thank you for joining me tonight and for participating in our journal club.
Thank you so much for this invitation. I look forward to it.
Great. So let's go ahead and get started. So what inspired or prompted you to take a look back at this classification? Was there anything you saw in your treatment of these patients that you saw something different going on with the classification system?
Well, for many years, I felt that the Hawkins classification didn't accurately portray the real risk for osteonecrosis. I mean, it's a classification system that's based on the initial fracture displacement and the implications of that on damage to the blood supply and thus the resultant osteonecrosis that can happen. And so it seemed to me that particularly the group 2 injuries that Hawkins described, that is those with a subtalar dislocation or subluxation, is really a very disparate group. People who have subtle subluxation at the subtalar joint, maybe a few millimeters of displacement, yet never had a dislocation event, inherently would have less soft tissue damage and thus less potential for damage to the blood supply than those that sustain a complete dislocation of the subtalar joint. And so for the first several years I was in practice, I was really interested in looking at this in a little more detail, with the idea being that maybe we could drill down to what the osteonecrosis rates were when comparing those two groups. And so that was really the impetus for doing this project.
So that makes sense. So in your paper, you'd hypothesized, as anyone would, that delay in reduction would affect the rates of osteonecrosis. And as you mentioned in your results, it was not the case, but that it was somewhat underpowered to detect that difference. Do you believe that this would have held true had you had a larger sample size?
Yes, I do. I think it's interesting that most of the literature, in fact, all of it that I could find at the time, really reported the timing of fixation from the time that they presented to the hospital. They didn't report on the time to the reduction. They didn't report on the time after the reduction to the fixation. And so really missing those details leaves us kind of wondering as to what's going on. And it seems to me that the initial injury event is going to cause some damage to the blood supply, if it's going to, and to the surrounding soft tissues. Now, if it's not tearing the arteries, it's just stretching them and pressing on them because of the dislocation. By reducing it, you're going to relieve the tension on those structures and thus improve the blood supply. So it seems that if there are patients that have stretched but not torn vessels, an expeditious reduction would reduce the chance of them developing osteonecrosis. And so unfortunately, because these are rare injuries, our sample was underpowered to show that, or not. I believe that it is still a factor. It's just that in our study, if you look at table 2, the time into reduction is actually pretty fast. It's within several hours in the patients that developed osteonecrosis and those that didn't. So I think we need a much, much larger sample, probably a few hundred cases.
Yeah, it's hard to get that many patients with these injuries for sure. Were there any holdups to the study, either institutionally or just methods or anything like that? Did you have to make any changes at all?
We didn't really need to make any changes. It was more just, if I had to do it again, I would have been paying more attention and really been aggressive about trying to follow my own injuries, my partner's injuries, who, as they would come in prospectively, because, at a busy urban level 1 trauma center, many of our patients aren't very good about following up if they're doing okay. So we tend to see those that are having trouble, whether it's a orthopedic problem or some social problem. But those patients that following up. But the idea about getting further detail in the classification, specifically the Hawkins group 2, I think we wouldn't have changed that. It would have just had better follow-up and perhaps more patients.
So did after you completed this study, did anything change in your practice as far as management of these injuries? Was there anything after doing this study that really made a difference for you? And then even since then, has there been anything else that has changed your practice and management of these injuries?
So I would say a couple of things on that. One is that, when I trained at Harborview, and, we were instructed on 2-incision technique using dual lateral, medial lateral exposures to enhance visualization, accuracy reduction, and strategically place the implants. That whole piece hasn't changed. But I think that on the one hand, when I came into practice about 20 years ago, most of my partners were pretty much fixing these all in the middle of the night still. And I didn't believe that it mattered. And so I just decided that I was going to not do that. I was going to reduce the dislocations and then try to come back when the soft tissue permits. Now, unfortunately, as you would recognize with many Hawkins group 3 or type 4 injuries, of course, a closed reduction may not be possible. And so you're going to do an open reduction or at least a percutaneous assisted reduction. And so the bulk of my patients, if I could achieve an adequate closed reduction, I just would splint them and then come back, 10, 14, 20 days later when the soft tissue were amenable. And I felt like that allowed us to build up a pretty large case series of patients that were treated deliberately on a delayed basis as long as they were reduced. However, because my partners were doing these still in the middle of the night, it gave us a little bit of a sample of similar injuries to compare. And over time, I think that they began to change their practice as well, which is good. We talk and we kind of learn things from each other. I'd say the other thing that I started doing more of is we have better implants now in terms of more versatility with mini fragment implants. There wasn't as much available at the time that I started in the way of particularly 2.4 millimeter screws fixation. And so just having better implants with more screw options and things. And so I think I've scaled down and used smaller plates, smaller screws, and really achieved the same outcome. But particularly for those that have associated lateral process or body fractures, I think I can stabilize them more effectively with modern implants.
Great, thanks. One other thing about the paper, what are your thoughts on those fractures that are associated with metamalleolar fractures compared to those who do not have metamalleolar fractures? Can you discuss how your paper may have affected your thoughts on that?
I think that's a really fascinating question because as you realize, a large portion of the blood supply comes through that deltoid branch. If the deltoid remains intact, because there's a metamalleolar fracture, it has always seemed to me that if the talar body dislocates, fractures through the medial malleolus as it displaces, because that artery is still intact, you'd expect them to have a lower rate of osteonecrosis. And so one of the things that Dr. Moore and I talked about a little bit is it would be really fun to be able to see that. Now, we didn't write that out as a formal hypothesis of this study, or it's certainly not in the paper, but I don't believe we're powered to do that. Not enough of the patients had a metamalleolar fracture. We have to have a much larger series. But I think it's interesting, and I would speculate that it's probably a good prognostic feature if you have that metamalleolar fracture. Furthermore, it gives you a really nice view of that whole corridor, the posterior aspect of the talar neck into the talar body in terms of more accurately assessing the reduction and your fixation. And if you do have a talar body element, many times you might do a metamalleolar osteotomy even to address that. So it saves that work for you. So I think it is a favorable thing.
Yeah, it definitely can help out when you really got to get back there, especially in the more body fractures. Is there any part of the message of the paper that you feel that sometimes kind of gets lost in translation?
Yeah, that's interesting too, because I think for quite a while now, most people have recognized that the time of fixation itself probably does not impact the rate of osteonecrosis. And we've looked at this, Tampa's looked at, Harborview. A lot of places have looked at it. Many surgeons have studied that for quite a long time. That the timing of the fixation, don't make mention of the fact that hey, you don't ever have to take care of these in the middle of the night. And I want to clarify, we need to expeditiously reduce dislocations. Any time of the day, those should be reduced, but the timing of the definitive fixation seems to not impact the rate of osteonecrosis. And so it's important to alleviate the tension on the soft tissues, which may include part of the blood supply. But if for nothing else, you don't want to leave something dislocated because you're going to be tenting the skin and predisposing yourself to having a lot more soft tissue damage and risk for infection. And so that piece I think is still getting lost a little bit, unfortunately. And so as a public service announcement, this is a good time to mention, we really should be expeditiously reducing those dislocations. But the definitive fixation, delay it as needed for soft tissue or for patient systemic illness.
Totally agree with all that. Thanks. Is there anything that you would have done differently looking back now, as far as the study goes?
Yeah, I think that would have been more aggressive about trying to keep these people tucked in so that we had better follow-up and longer radiographic follow-up on some of them. I think I also would have called out to some of my friends at other large centers to see if they wanted to pool the data, because this is a large series of talus fractures, but if we would have had maybe a half a dozen other hospitals, I think we could have done a lot more with it, maybe looking at that malleole question and really ironing some things out that could be more definitive, because it's a very difficult fracture to study, but there are a lot of centers that have approached them technically with a rather like-minded concept, and that could have been helpful. So looking back, that would have been something that I would have made an effort to do.
And just finally, what are the take-home points of the paper to you? Like, what do you want everyone to really know about it?
So I would say the take-homes are, these are injuries that you want to very quickly identify and expeditiously reduce the dislocations. After that, the timing of the definitive fixation is not so important, other than waiting for the soft tissues and the patient to be ready to do that, and doing it during the day when you're fresh. These are difficult injuries, and you want to be extremely accurate with your reduction, your fixation, and generally I would advocate a 2-incision technique in order to do that accurately. But I think the risk for osteonecrosis is really related to initial injury features, the presence of open fracture wounds, and the initial fracture displacement in particular. The presence of a medial malleolar fracture may be protective. We don't have data that support that, but that's my speculation. And there's other patient factors, diabetes, tobacco use, things that inherently would affect microcirculation and thus predispose to more complications. Again, that really hasn't been shown, but it makes sense that it would, because it's relevant in other literature. The other thing I would say is that if you're just a casual operator in this area, you may want to transfer these patients and send them to someone who does a few more, because they're not easy. They're very challenging, and it's difficult to get a series of them. So it's nice if you have colleagues that you train with, or if you're doing a trauma fellowship, try to do a lot of these, do as many of them as you can get access to in your practice, because they are difficult, and the soft tissues don't take a joke. And I think if you're not as experienced, you're more apt to damage the blood supply that remains. You really don't want to be dissecting dorsally over the talar neck and planarly and disrupting anything that might still be there in the way of blood supply. And that further, of course, undermines your soft tissues in general and predisposes you to higher rates of wound dehiscence and soft tissue complications.
Well, thank you for taking the time out of your busy schedule to meet with me and us and talk about this very interesting paper. And have a good night.
You too. Thank you so much for this opportunity.